Junk for Jesus, the commodified gift, donation, in a global economy. My presentation today is going to begin with providing you a brief background and description of the project's origins, and then that will provide you with an understanding of the research problem. This will be followed by the research question, and then a discussion of the contributing factors to the problem. I will then present my proposed new methodology for inserting an intervening negative feedback loop into this system and conclude with recommendations. In December of 2006, I was in San Benito, Petén, Guatemala, visiting my friend Foster Ortiz, who is the hospital administrator for a small charity-run hospital. At the time, they had just received their license from the Guatemalan government for a 20-bed hospital. It was here that I was first introduced to the phenomenon of junk for Jesus, which is the act of giving any gift that is not of use to the recipient. Hospital Shalom was reliant on donated medical equipment and supplies from NGOs, non-governmental agencies, in order to be able to provide medical services. The problem was that much of what they received was broken, obsolete, inappropriate, missing parts, and or potential toxic waste. I began that day to document through photographs, and photographs provided to me by Foster the various items that had been donated to them and were what Foster called junk for Jesus. Another friend, who is the administrator for a community free medical clinic in El Ramate, Petén, Guatemala, and who provides free medical care for the village, for that particular village, and is also reliant on donations of medical equipment supplies, told me, quote, "We're tired of being the last stop before the landfill." What she meant by this was that much of what is received was at the end of its useful life cycle, with little or no usefulness left, and that they were the ones who had to pay to dispose of it and dispose of these donations in landfills. In Guatemala, landfills are also the homes of families who earn their living scavenging from what is dumped. Perry and Malcolm of Duke University's biomedical program conducted a limited field research project tracing donated equipment and assessing how much of it was useful. Their study found that 40% of all donated medical equipment is not in use. This brings us to the research problem. Medical equipment has increasingly become state-of-the-art, high-tech, computerized diagnostic and monitoring equipment. As such, this equipment is exactly the same as end-of-life cycle consumer electronics. It is e-waste. E-waste is any item that contains a printed wire circuit board and plastic-coated wiring. E-waste is your smartphone, programmable coffee maker, laptop computer, iPad, and every piece of medical equipment that contains a printed wire circuit board. E-waste disposal and recycling is a global problem with an estimated 40 million tons of e-waste being dumped annually, and that number is increasing every year. Unfortunately, the recycling of e-waste is not a state-of-the-art operation, and much of it is done informally. E-waste contains the following developmental neurotoxins: mercury, cadmium, hexavalent chromium, brominated fire retardants, polychlorinated biphenyls, dioxins, furans, and polycyclic aromatic hydrocarbons. Researchers conducting studies in China at e-waste recycling and disposal sites detected measurable concentration levels of the neurotoxins in the bark of trees, human hair, breast milk, blood serum. The United Nations Environmental Program has authored a study on the importance of e-waste recycling and notes that most e-waste that is sent to developing countries is recycled through open-air incineration. This releases into the atmosphere all of the neurotoxins to be absorbed by the local community and their visitors. The research question for this thesis was how to stop the flow of end-of-life cycle donated used medical equipment from ending up in the landfills of the developing world to be burned in the open air. So what are the contributing factors for end-of-life cycle medical equipment to be donated? The first contributing factor is neoliberal political and economic policy that has promoted privatization, free markets, and globalization. The second is an offshoot of neoliberal policies, and that is the growth of private non-governmental agencies, NGOs, replacing the state to provide public good services to their citizens, to groups in needs, and to developing countries. The third is the role of social psychology in developing advertising and fundraising methods that exploit the psychological benefits of giving to the individual giver through the creation of the objectified other who is in need. Neoliberal policies have promoted the privatization of healthcare to the private sector and away from public health models. Neoliberal theory contends that privatization of services leads to competition, which leads to better services for less money, and that should result in increased access to services. I will briefly give one example where the implementation of neoliberalism has had the opposite effect. Chile is an example where neoliberal economic reforms were implemented approximately 30 years ago. Unger et al. Note that prior to the implementation of economic reforms in Chile, the Chilean healthcare system was largely a public healthcare system. The neoliberal reforms instituted both a public and private system. The public system utilized taxes collected from all wage earners to provide a system of public hospitals. Alongside this, the government created a private insurance system. The intention of the reformers was for the private system to become dominant so that persons with private insurance receive care and relationship to their individual contribution through the price of their policy rather than through a redistribution of services based on paying a percentage of income to the government. Their research concluded that the private system favored the economic elite and in particular young males with little or no health care problems. Conversely, women and the poor were excluded from purchasing private health insurance based on their higher need for medical services. The research found that the implementation of privatized health insurance did not reduce the amount of money spent on health care, with expenditures being higher in the private system than in the public system. In discussing the inequalities created by the private insurance market, they note that 40% of private healthcare expenditures benefited 16% of the population. Their conclusion is a recommendation for Chile to remove their private multi-layer insurance system and implement a single-payer system. In developing countries, NGOs, who are private organizations, have increasingly taken on the role of delivering public goods services. The act of removing the state from providing services to its citizens and transferring this obligation to private organizations depoliticizes these services. NGOs in the medical equipment field actively collect and distribute used medical equipment. Journals and publications directed toward medical administrators, materials managers, and nurses tout the benefits of this system of giving donations. The donors believe that even though their equipment has become old and obsolete, and that it is no longer life-saving in their settings, it becomes life-saving again as soon as it is donated. NGOs use the monetary benefits of donation to motivate healthcare professionals to give donated equipment. NGOs also promote the benefits of clearing out hospital storage areas of equipment that they will no longer use because it is unreliable, obsolete, broken, or missing parts. Social psychologists who work to assist NGOs in deciding fundraising appeals have found that one of the most effective methods to elicit giving is by the creation of the other as an identifiable victim. This transforms societal problems to problems of the other and allow for the idea that something is better, that giving something is better than giving nothing. My hospital administrator friend expressed his frustration to me that it was the NGOs who decided what equipment was beneficial for him to receive. The NGOs are the ones who sort and pack the equipment, and then they ship these items to the developing world. The recipient organizations have no say in what equipment they receive. This is donation as a discourse of power. NGOs as organizations are privately run, with mission statements and vision plans that promote the goals, aspirations, and worldviews of their board of directors and major donors. NGOs operate in the realm of governmentality. What they give, who they give to, the condition of the items they give, all speak to the privatized nature of donation. NGOs are in effect regulating what donations are distributed and to whom. They control the quality of donations they deliver and to whom, and they restrict the recipients from being able to exchange or sell any donations that are not useful to their patient populations. The relationship that NGOs have to corporations, hospitals, and clinics that donate equipment to them is such that they are complicit in the externalization of e-waste disposal costs to the recipient groups in developing countries. Meanwhile, they report to be providing health and hope to the world. This has led me to propose a methodology for receiving medical equipment donations that would track the individual donation and its cost-benefit value to the recipient organization. I call this a Med-BCA. The recipients of donations need a way to assess the monetary values and costs of each donated item that includes the environmental societal cost for its future disposal in the landfills of the developing world. Resource economics and natural resource damage assessment in a combined tool can provide recipient organizations and their governments a tool to assess the costs and benefits to their patients, their communities, and to their ecosystems. Resource economics allows us to assess an item for its monetized value, just the same way that donors are able to self-assess their fair market value of a donated item and write it off. Recipients would be able to assess the monetized benefit value of donation. Natural resource damage assessment is the legal tool that allows for litigation for recovery of damaged monetized natural resources. Recipient organizations that are within a biosphere reserve or a UNESCO World Heritage Site are examples of groups who can utilize this particular component. This involves having a monetized value for the economic benefits of a natural resource. For example, the economic value of ecotourism or the value of an aquifer. This does involve monetizing or setting a value on a specific natural resource. To briefly explain how the Med-BCA would work, I've created a simplified example. We have the claimed monetized value of a piece of equipment. Next, the piece of equipment is assessed for its usefulness. In this example, the equipment has arrived non-functional and cannot be repaired, so it is automatically given a value of 0. Next, all societal costs are deducted from the 0 value. These include transportation costs that have a separate line item for the CO2 environmental costs. Next are the costs for disposal, which again include transportation and the environmental costs of transportation. As you can see, this methodology demonstrates that the cost of receiving this equipment is greater than its benefit. The following are recommendations for further research. resource economists need to know the weight of the elements that are contained in different pieces of medical equipment. For example, if an oxygen concentrator is donated, they need to know by weight how much that piece of equipment contains of elements that are toxic to humans and to the environment. If the equipment contains lead, the amount of lead needs to be known, and so forth. This will require further research to obtain the amounts of toxic materials used in medical equipment. The next step would be to then partner with environmental scientists to determine the levels of each toxin that are emitted through